So we need to know that there are a lot of hereditary, idiopathic, infectious and systemic causes for the development of chorea. So among the metabolic and endocrine causes, we need to know hyperthyroidism, hypoparathyroidism, hypoglycemia, anoxic encephalopathy, and among immunological causes we have the systemic lupus erythematosus. Similarly, among the infections, HIV also can lead to the development of the chorea. So that is the reason, doctor, infections like HIV, SLE, and among the thyroid dysfunction, hyperthyroidism, all the three in fact are capable. Which is the? Okay, there is fourth alternative, at the end we will take up that, okay, that's good. Now if resistance vessel radius is increased, what will happen? What is that law called as, doctor? It is called as the Poiseuille's law. You know that to the fourth power of the radius, the resistance will be inversely proportional. So the bigger the resistance, bigger the radius, lower is the resistance, and that's the reason it will increase the blood flow, increase the capillary flow is what you need to fundamentally remember. And what are the resistance vessels fundamentally? We have got the arterioles and large arteries which contribute to the majority of the peripheral vascular resistance that we come across is what you need to fundamentally remember. Now by spirometry we cannot calculate functional residual capacity. It can be? Option functional residual capacity is not there? Total lung volume is there? Okay, residual volume is not there? Okay, anyway, we need to know what is the fundamental meaning of these values so that you can judge any volume in which residual volume is a component that cannot be calculated by doing the spirometry, because residual volume we cannot calculate by spirometry. So we must know that residual volume is a part of which volumes? It is a part of the total lung capacity. It is also a part of the functional residual capacity. I think with that logic you can just recorrect the total. If that is the option, then that becomes the answer, because the residual volume is a part of the total lung capacity, and residual volume we cannot calculate. So that's the reason. And how do you calculate residual volume and functional residual capacity, doctor? Plethysmography is an indirect way by which you need to basically calculate the residual volume is what need to be remembered. Now what is not a characteristic feature among the criteria of allergic bronchopulmonary aspergillosis? Is it a very traditional question? Very, very traditional question. So the International Society has given certain criteria: asthma, elevated aspergillus specific IgE, elevated serum IgE, proximal bronchiectasis and wheal and flare reaction, blood eosinophilia, presence of serum precipitants to the aspergillus antigen, and this kind of transient or even fixed pulmonary infiltrates which are fleeting in nature, they all become the part of the definition of allergic bronchopulmonary aspergillosis. So culturing the aspergillus from sputum is not a part of the criteria, whereas asthma and precipitin of the aspergillus and lung infiltrate, they are all the part of the criteria is what need to be remembered. Now comes our favorite topic, renal tubular acidosis. What is the missing question topic in the question paper which generally comes in entrance? Barter's, Liddell's and Gitelman is not there. To compensate that, we have at least a renal tubular acidosis. Now let us talk about it. You don't find the Fanconi's anemia as a part of distal RTA. Fanconi's is fundamentally a proximal renal tubular dysfunction which is a part of type 2 RTA rather than type 1 RTA. So there ends the story. All the remaining things are true. Type 1, type 2, type 3, all the three are hypokalemic type of renal tubular acidosis is a well known fact. Which is the only hyperkalemic RTA? Type 4, which is seen in diabetic nephropathy, where there is no renin production. There is a hyporeninemic hypoaldosteronism which lead to development of hyperkalemia in type 4 RTA, which is seen in the case of diabetic nephropathy, as all of you know very well. Now why do you have hypocitraturia? I know that it is not really required, but you must be sure on some facts. Why there is a hypocitraturia in the case of renal tubular acidosis is my question to all of you. At least we don't talk about what we can otherwise talk that leaves us with a dissatisfaction. Let us talk about it. What is hypocitraturia? Basically in the proximal renal tubules there is a constant production of citrate, which is a part of the citric acid cycle. What happens in renal tubular acidosis? In renal tubular acidosis, there is an acidosis which leads to proximal tubular cell intracellular acidosis, and that intracellular acidosis will exhaust the citric acid cycle intermediates, so the citrate will become less available in the tubular fluid, and that lead to development of hypocitraturia. So the presence of acidosis will drive more citrate reabsorption and less amount of citrate inside the urine. Normally what is the role of the citrate in the urine? Citrate will bind with the calcium and prevents the calcium stones from forming. Any hypocitraturic state is a predisposing factor for the nephrolithiasis and the precipitation of the calcium stones, and that is the reason there is a more tendency towards the nephrolithiasis in a patient of the renal tubular acidosis is what you need to remember. So there is a reason, doctor, there is a hypokalemia, there is a nephrolithiasis, there is a hypocitraturia, because acidosis will lead to hypocitraturia. All the part of the renal tubular acidosis is what I want to underscore to all of you. Now seminal vesicles, palpating them is a normal finding in rectal examination, but okay, commonly found in. Now tell me, doctor, do you find it in prostatic cancer or in genital tuberculosis? How many would like to elect for prostatic cancer? It is a part of the staging of the prostatic cancer, we accept it. But more commonly, if at all that adjective is there, then I would like to prefer tuberculosis. The genitourinary tuberculosis is one of the much more a common cause leading to the seminal vesicle palpation. I don't know what is there in the examiner's mind, but I am sure genital tuberculosis is a part of the options. When tuberculosis is the option, there is nothing else which can stand before it. It is like a national party, where all the other conditions are the local parties. So that's the main problem. Now let's go to the next question. Prostatitis, yeah, acute prostatitis, and we have the prostatism as a part of it. We'll take up, but on any given day, tuberculosis genital is the most common. Now intermediate mesoderm, it will be giving rise to what? This is a bouncer. I think first bouncer of all the questions in the given, right? Embryology is not even read at a embryonic level also in our MBBS, because probably we would have read, if you remember till now means there is only one reason, probably we failed in anatomy. If we pass in anatomy, we don't remember about what is intermediate mesoderm. So let us talk about it. We need to know, doctor, there is a paraxial mesoderm, there is a lateral plate, between the two you have this intermediate mesoderm. It is a part of the urogenital system formation. In males, what does it form? The Sertoli cells are the derivatives of the intermediate mesoderm, Leydig cells are the derivatives, but the spermatogonia and primitive germ cells, they don't come from the mesoderm. Rather, they are all basically derivatives of the yolk sacs ectoderm germ cells, is what you need to remember. Similarly, in the differentiation of the ovary, the follicular cells are the derivatives of the intermediate mesoderm, but the oogonia are the derivatives of the yolk sacs ectoderm. So that is the fundamental difference. That's the reason, in summary, Leydig cells, Sertoli cells, follicular cells of ovary, all the derivatives of the intermediate mesoderm, but not the germ cells, becomes the answer for this question. Now, which is the antiretroviral? How many questions are there on HIV, doctor? 4 or 5? That is, examiner did not do mistake. It's a conventional paper. After marriage, there must be a honeymoon. After that, there must be a fight. After that, there must be a reunion. After that, there is a childbirth. So everything is in a very conventional manner. Suddenly, if you cry that I had a fight, means you are expected to fight. If you are not fighting, means probably you built a pillar between both of you. So that's the reason This is not a tough paper. Please let us not say that it's tough, because expected to know about antiretrovirals. So we need to know, doctor, that enfortumab is a HIV fusion inhibitor, and it is the one which is fundamentally given subcutaneously, and it is a peptide substance by nature, peptide. So you can't take a peptide orally. You have a lot of peptidases in the stomach. So you prefer to have a peptide which is given subcutaneously, is what I like to underscore to all of you. Then what is indinavir? Expected question only. So we need to know that zidovudine, diadenosine, and zolcitabine, lamivudine, tenofovir, etc., they are all nucleoside reverse transcriptase inhibitors. Then we have nevirapine, efavirenz, and dilaverdin, which are all NNRTIs. Then we have sakinavir, indinavir, lopinavir, and all these which are protease inhibitors. So indinavir is a protease inhibitor, as all of you know very well. And you must be sure each of these drugs, what is the mechanism of action, is a favorite topic of the examiner. Then where do you have Grisinger's sign? Another biscuit question, I am very sure you answered. So it is in the septic thrombosis of the lateral sinus, there is a thrombosis of the mastoid emissary veins, and that lead to a retroauricular edema, which is basically called as the Grisinger's sign, is what need to be remembered. What is Maraviroc? This can be a bouncer. If you did it wrong, don't worry. You can put it among expected permitted answers, permitted wrong answers. So CCR5 antagonist, it is produced by the Pfizer company by the brand name called Maraviroc. So it is basically a CCR5 inhibitor. Then what is CCR5, doctor? This HIV fellow, for him to enter into the host cell, he requires some invitation. Sir, please come, sir, please get into the flight. After that, please enter. Otherwise, somebody is not inviting HIV, doesn't know how to get inside. It is very bureaucratic in nature. So how can you prevent him from entering? You stop that receptor. CCR5 receptor blockers is the one which will prevent the helper T cell infection by the HIV virus. That is the main role of the Maraviroc, is what need to be remembered. Now ectopic test is, where do you find it? We find it in the superficial inguinal ring. So you can see this is an example of a 10-year-old boy, T2-weighted coronal MR, where you can see the hyperintense testis in the right groin, and the superficial inguinal pouch is the most common location, is what you need to fundamentally remember. Now where is glucagon not present? We will have an argument and fight in the end, don't be angry. I'll give my humble answer about this. GIT, I think you all agree. Much easier is pancreas, you will agree. Okay. Anybody answered pancreas in the answer except about it? No problem. So then GIT, we accept. Only thing is it brain or is it adrenal? So there is a glucagon like peptide 1 is the one which is released both by the brain and also intestine. At least from the literature I have. Maybe you may come out with a journal saying that this adrenal glucagon is found to have an importance in mood disorders. You may come up with a new theory. So, but I don't find that reference. That's the only thing. So I put conventionally as adrenal. Don't be angry if you answer it as brain, no problem.